Hello everyone, welcome to TEPHI's Infection Prevention 104 module titled Infection Prevention and Control Programs. Before we begin this module, we would like to briefly introduce what TEPHI is. The Texas Epidemic Public Health Institute is a state organization that is headquartered at UT Health School of Public Health with the goal to keep Texans safe and the Texas economy strong by preparing for the next infectious disease outbreak. If you're interested in learning more about TEPHI, we have a few QR codes at the end of this module that can guide you to different resources. My name is Oluwatoyin Akanji, and I am part of the Small Rural Healthcare Systems program at TEPHI. I graduated from Rural University with dual degrees in biology and health sciences, and I have years of experience providing infection prevention education to communities. The second presenter today is Kayla Rush, an infection prevention practitioner who is certified by Public Health, Healthcare Accreditation Process, and Infection Prevention and Control. During the pandemic, she had the opportunity to work at acute care hospitals in Texas, New York, and California before returning to UT Health to pursue a PhD in epidemiology with a concentration in infection prevention and control. The first section we will discuss today will provide you with a brief overview of infection prevention and control program components. This module learning objectives are to describe infection prevention and control programs, to describe epidemiological investigations, and lastly, to describe and explain effective communication and management practices. Infection prevention and control, which is commonly known as IPC, is a practical evidence-based approach to preventing patients and healthcare workers from being harmed by avoidable infections. Effective IPC requires constant action at all levels of the healthcare system, including policymakers, facility managers, health workers, and those who assess health services. IPC is unique in patient safety and quality of care, as it is universally relevant to every health worker and patient at every health interaction. Defective IPC practices and programs can cause harm and can potentially lead to fatalities in a healthcare system. Infection prevention and control involves all aspects of healthcare, including hand hygiene, surgical site infections, injection safety, and how hospitals operate during and outside of emergencies. How important are infection prevention programs? The World Health Organization found that where good hand hygiene and other cost-effective practices were followed, 70% of HAIs could be prevented. Also, out of every 100 patients in acute care hospitals, 7 in high-income countries and 15 in low and middle-income countries will acquire at least one HAI during their hospital stay. That is, on average, 1 in every 10 patients that would die from their HAI. So infection prevention programs are important in providing a safer environment for patients and staff by guiding safe practices. Today, we will briefly cover some of the core components of IPC programs. Depending on your facility, additional or different components will be involved in the infection prevention program. One component we will be discussing today is employee and occupational health. But this is important. This is an important aspect of IPC programs. In some facilities, infection prevention and control and employee and occupational health are joined together, but in other facilities, they are under different departments. The components of IPC programs that we'll be discussing today are surveillance, healthcare associated infections, which are HAIs, hand hygiene, isolation compliance, high-level disinfection practices, sterilization practices, construction, and education. So we'll start with surveillance. Surveillance is a very important aspect of an effective IPC program. The CINIC project, which is the study of the efficacy of nosocomial infection control, showed that hospitals with good surveillance programs were able to reduce their HAI rates. For surveillance programs to be effective, they should be based on epidemiological and statistical principles, should be able to identify outbreaks and pandemics, and lastly, should be designed according to current recommended practices. As a review, some common surveillance terminology often gets misused. For effective communication, using the correct terminology is very important. As an example, incidence and prevalence are terms that are commonly misused, and incidence is the number of new cases, while prevalence is the number of already existing cases. In the next slide, we'll be discussing the design of an effective IPC surveillance program. When it comes to surveillance methods, there are two main methods. We have total surveillance and targeted surveillance. Total surveillance involves monitoring all patients within a healthcare setting, offering a total view of infection rates. On the other hand, targeted surveillance focuses on specific patient groups, procedures, or pathogens. This approach is efficient for directing resources where they are most needed. A critical step in designing the surveillance program is to assess the study population. Consider the types of patients that are in a facility. Could be newborns, geriatric patients, immunocompromised patients. Different departments might have different infection risks due to the nature of the services that are provided. So as part of the study population, you could consider services provided like medical or surgical services and low or high risk. One crucial step in designing a surveillance program is selecting appropriate health-related events to monitor. These events could be occurrence of HAI, health alerts, or presence of pathogens that are highlighted in the IP annual plan and risk assessment. Once we've determined the events to monitor, the next step is determining the observance time period. This period establishes a time frame over which we'll collect surveillance data. So for valid measurements, it is necessary to use an observation time period that is long enough to accumulate a sufficient number of events. This could be a defined period such as a year, a month, or a quarter. To ensure that we're capturing relevant data, we must identify surveillance criteria, which is often referred to as case definitions. Make sure that you're developing a clear and standardized definition for each HAI to ensure consistent reporting. Identifying the right data elements to collect is another important aspect of designing a program. Collect data that are needed to identify a case and determine whether the case criteria are met for the condition or event being monitored. This could be patient name, medical record number, date of birth, or sex. As I mentioned earlier, there are two main types of surveillance programs, total or whole house surveillance and targeted surveillance. Whole house surveillance involves monitoring all HAIs across the entire healthcare facility. And this should be done when you want to look at already existing cases or if the facility is so small that you cannot analyze the data meaningfully. Targeted surveillance, on the other hand, focuses on high risk and preventable procedures that are significant to a unit or department. For example, this approach might involve closely monitoring infections associated with the use of medical devices in the ICU. Targeted surveillance means that efforts can be tailored to the needs of each department. And by identifying the specific risks that a particular unit faces, we can develop surveillance strategies that make the most impact in that unit. Before you start collecting data, determine what measure you're going to use to analyze your data. It is, if possible, data should be analyzed using rates or ratios because it allows for accurate comparison with other surveillance programs. There are different methods that you can use to collect data. We can use medical records, incident reports, interviews, observation, or procedural logs. Identify what method works best for the type of data you need and collect the data using data collection forms. The NHSN uses a standardized collection form, and you can either use this as a guide in creating your own, or you can use it like that. Develop a report that can be used to interpret the data you have collected. This should include the description of the event, population and setting, the criteria used to select cases, the number of cases that were included in the program, the methods you used, and lastly, the findings of your program. Present the report to leadership or stakeholders in the facility that can use these findings to identify and implement safe protocols, evidence-based infection practices to improve outcomes in that unit. After writing and presenting the report, a surveillance plan should be written. This could include the type of program that was done, the events and criteria that were used, the methods that were used to identify cases, and also the reports that were written about the program and who they were provided to. Now I will turn it over to Kayla, who will discuss more on the IPC programs.
Thank you, Toyin, for that introduction. As Toyin mentioned, my name is Kayla Rush. I'm an infection prevention practitioner. One of the big surveillance programs that we use specifically in infection prevention and control practices is the National Health Safety Network, as Toyin mentioned, or NHSN. This surveillance system is specifically designed under the CDC, and it really helps establish if an HAI or healthcare-associated infection has specifically occurred in your facility. Statistically, about 1 in 31 hospitalized patients will at least develop one HAI here in the United States. So this is a very, very relevant and important problem that we have. The goal in a hospital admissions is always to provide a safe environment with best quality of care for our patients. But however, sometimes there are processes breakdown, lack of resources, opportunistic organisms, or issues with our cleaning, sterilization, high-level disinfection practices that lead to these types of infections. The CDC National Health Safety Network, NHSN, is used as a surveillance system to track HAIs in our facility that provides facilities, states, and regions in the U.S. with data to identify these problem areas, measure progress on prevention efforts, and guide in elimination of HAIs. This is a major component of an infection preventionist's time. They will spend a lot of their time reviewing and determining if an infection meets this specific NHSN criteria. After an HAI has been confirmed by an infection prevention and the department, it is then informed to leadership that an event has occurred, and then the next step would be to hold a root cause or a gap analysis to see where there was processes breakdown or opportunity to gain improvement on our patient care to help reduce these types of infections or eliminate them in total. The main type of HAIs that NHSN looks at and a lot of facilities track and trend are the following. They're central line associated bloodstream infections, also known as CLABSIs, catheter associated urinary tract infections, known as CAUTIs, surgical site infections, which are called SSIs, ventilator associated pneumonia would be a VAP, and then healthcare associated MRSA. Next module, in module 5, we'll go into depth about each of these criteria, look at the definitions, and kind of give some practice examples of looking at how the criteria is met and the epidemiology importance of it. So stay tuned for module 5, which we'll have in November, and you'll see an announcement at the end of the presentation. So another big component of infection prevention practices is clean hands. We talked about this extensively in module 1, and it's the single most important factor in preventing the spread of pathogens and reducing HAIs and providing a safe place to work as providers and for patients. As we discussed in module 1, hand hygiene compliance should be tracked, audited, and we went through those audit forms. So if you need a refresher, please look back into module 1. You can see examples of the CDC forms and kind of how it was tracked and trended. Not only should we be tracked and audited this to help really increase our hand hygiene culture in our facility, then we need to be trending this data and talking about it monthly, quarterly, and annually at our infection control meetings, our other quality meetings, so that we can help increase the culture of hand hygiene compliance in our facility. So here's just an example of how your hand hygiene data can be broke down, and as we referred to in module 1, to our leapfrog score and our CMS and Joint Commission regulations, they want to see how many observations per unit per area. So you definitely want to be able to show that reflectively. So you want to be able to break it down per unit and calculate your compliance rate, which is your denominator of your total observations, and then with your compliant observation as your numerator to help you calculate your compliance rate, as you see here. Each area is then specifically given a rate or of your hand hygiene, and it's a really great way to see where in the facility there's opportunities for improvements of hand hygiene culture in specific areas. Then with all that, you want to calculate your overall facility rate and trend that as well. And here's just an example of trending your hand hygiene data throughout the year. A lot of this data will go into our infection control risk assessment, our infection control plans that we do annually. So it's a really great way to quantifiable, see what your culture is doing, and identify areas of opportunity to improve. This is also great to look at kind of annually to see if there's areas that may be weighing on hand hygiene compliance, and also look at seasonal issues such as cold and flu, making sure when we're in those periods of increased infectious workup that our hand hygiene culture is really increased as well, and that we can help reduce the spread. So another core component that goes along with hand hygiene compliance is isolation compliance, and isolation compliance is broken down into two main areas: our patient isolation compliance and our staff isolation compliance. Our patient isolation, we look at isolation orders, we look at our signage, our room assignment, cultures documented and performed. And then on the staff side, we look at our stock of PPE, our compliance of PPE, and our ability for our staff to really talk about the mode of transition of the infectious organism and justify the isolation as well. So in the first part of it is looking at patient isolation compliance. And that first starts with our room assignment. Anytime you have an infectious patient or someone under investigation, UPI, you always want to assign them to a single room so that you don't have patient-to-patient spread. If your facility is at capacity, then you kind of have to get creative like we did with the pandemic and the maybe cohort based on the infectious organism that both patients have. So if available, the best practice is to put them in a single room, and then that they might require negative pressure based on the infectious organism, such as with COVID and TB requires negative pressure for those rooms, but other infectious organisms such as C. diff, MRSA don't require negative pressure. So it's good to be mindful, and then with your patient flow on your floor in your unit, that staff are thinking about the physical placement of patients so that we're not having to change rooms based on the HVAC requirements for a specific person. So you're not having a non-infectious patient being put in an isolation room and then have to move them later for an infectious patient, just to help overall hospital throughput and patient assignment as well. The next step is to physically placing your isolation orders. There should be a physical order set in your EMR that dictates, yes, this is isolation requirement. And this is also very important, especially when it comes to Joint Commission and CMS and the local health department. They will specifically look at when was this infectious patient identified, when was isolation started on them, and then from a regulatory component as well, when was the order specifically set to. So they will look at that along with documentation. So not only should the order be placed, but there should be a note saying, hey, this person's on contact isolation for potential C. diff or MRSA or TB or whatever organism that you're looking at, but as a note as well to indicate justification for that order set. And then we're looking at signage that should be placed on the room. It should be outside, visible, so that anyone in the area knows, hey, I need PPE going into that room, and we know what to wear so that we can stay safe at work. And then lastly, our cultures. For anyone that's getting ruled out for an infectious organism, we should have cultures documented and ordered. And we always want to make sure that they haven't accidentally dropped off of, one attending or physician or nursing staff putting in an order, maybe wasn't able to collect it because patient wasn't having diarrhea, didn't have to void their bladder, any of that. And that's communicated to next shift so that the culture is physically collected and then sent down, and then confirming with the lab that they have received it, that we have sent the right culture in the right specimen to, it has been accepted at the right dilution or quantity, and then we are looking at our results. Now, when we're getting our results, we want to make sure that we're cross-referencing our specificity and our MIC reports of seeing what type of infectious agent this patient has, or does the culture come back clean and we can decrease isolation and we can get that person out of isolation and really help get them discharged quicker as well. And then when you're checking if it's a positive organism, that the antibiotics match and that they are sensitive to that antibiotic so that we have good antibiotic stewardship. And if when you're reviewing there's a mismatch, such as they're on penicillin and the organism is penicillin resistant, then you're contacting pharmacy or the attending physician to know that, hey, drug administration needs to be changed based on the cultures. And then more, as we talked about extensively in Module 1, we're looking at isolation compliance of our donning and doffing of our PPE. So we're knowing what to wear to be safe at work. And this goes to staff and visitors as well. If anyone, and depending on your policy at your specific facility, visitors may or may not be allowed in isolation rooms, or depending on the organism that the patient is getting worked up at, just as an exposure and safety measure. So review your specific policy to look at if visitors are allowed on those isolation rooms and that people are being compliant with their PPE. They're not wearing it in the hallways or common areas, so we're not exposing, and then we're having that spread from non-subcomosial sites as well. And then, like any metric, we want to make sure that we're monitoring, so that's tracking and trending in a quantitative way. And here's just an example of a couple things that you can look at. Specifically, when we're looking at isolation, as I mentioned, the sign is posted on the door. It's visible, so it's not under, it's not hanging off, you can see it, it's clear. There's an isolation cart outside of the room with the proper PPE in it, needed to take care of that patient. And then the staff can say what isolation they're on and why, and if that's appropriate. So making sure they're saying, oh, this patient's being ruled out for C. diff, they're on contact isolation. That is a true match compared to, oh, they're on contact isolation, but they have a respiratory organism, which then they should be on droplet or respiratory precautions instead. So definitely verifying that the organism match the isolation, and you can specifically look at the route of transmission for that. And then just another really good resource that anyone can use is CDC Appendix 4. Is a great reference. It has all the organisms with the specific isolation that they require in the facility, and the link to that appendix is at the end of the slide deck, will be available for everyone. And then other things to look at when you're monitoring isolation compliance, specifically observing people donning and doffing before they go in, performing hand hygiene before and after with PPE. Are they taking any reusable equipment into that room? And if so, that's okay. But then that we are cleaning that equipment appropriately according to the instructions for use, or the IFU. So making sure that's being done so we don't have patient-to-patient spread or patient to healthcare worker spread, that we're handling that dirty device and then we're getting it on our scrubs, and then you have transmission that way. And then again, we have isolation noted in our EMR, and also education documented that both the patient has been educated, they know what's going on, they know why people are coming in PPE, because it can be a very scary process, especially if you're not used to that type of environment, so that they are fully aware and they can partake in their care plan, and that the staff have been educated on what precautions that they need as well. And then you'll calculate your total, give a level of compliance. Anything that's under 100%, you're then talking to that staff or that unit about what you're finding, so that they can properly address it and maybe do some training and re-education based on it. So the next component that we're going to talk about is high-level disinfection practices. We briefly talked about this in Module 3, and it is, HDL is required for semi-critical items, which that are items that come in with mucosal membrane or not intact skin. Here's just an example of some items. Depending on your facility and your service line, you might have more or less. And like any good practice, we want to make sure that we're auditing to ensure that no harm is coming to our patients and things are being high-level disinfected appropriately and according to the instructions for use, or IFU. So here's just some areas where typical high-level infection cleaning process for the devices that they use are. There might be more or less. And then when you're auditing, the main 4 areas that you want to look at is point of care cleaning, which means at the bedside, transportation of that device to the reprocessing or high-level disinfection area, and then watching the cleaning process either manually or mechanically, and then verifying those practices. And then we'll talk about each in detail next. So the first step of auditing high-level disinfection practices is coordinating with that specific unit or that procedure that, hey, a procedure is going on, I'm gonna come in and audit it. This is a great way, one, for you to be educated and to verify that your staff is doing the right thing, and it also gets your staff very comfortable in the auditing process. So especially when Joint Commission and TJC show up, that they feel comfortable having a third party watch them and kind of getting them used to the questions that they will ask and kind of being in the room as well. So you'll want to coordinate a time in our procedure to go in so that you're there at the start and you're wearing the right stuff so that you're not disrupting the procedure and causing increased traffic flow. So the first thing that you'll do while you're in the room, donned appropriately in the proper scrubs and PPE, is see the visual cleaning or removal of visible tissue or fluids from that device. So that will be with a sterile sponge or a lid-free cloth from the stem of it all the way down to that device, and it should be one motion, one direction. So you want to remove the physical tissue or blood from that device and then see it being placed in a puncture and leak-proof transportation container, and the keywords for that is puncture and leak-proof. Once it's placed in the container, you want to spray it with your enzymatic spray, which the enzymatic spray helps decrease the bioburden and biofilm from forming to make it easier to clean. So then you want to see it sprayed, and at that point, that enzymatic spray should keep that device completely wet until it's processed. Every spray has different wet time and different amounts that you need to spray, so make sure that you're looking at your products in your facility to make sure that you're in compliance with how they should be used effectively. Then you're going to physically move down with the device to the high-level disinfection area. That might be on the same unit, that might be in sterile processing, or it might be in its own separate unit. There you're going to witness mechanical and manual cleaning. That will be doing the leak test, verifying chemicals, talking with staff, asking them how they are cleaning the device as they do it. And then you will see them place that piece of equipment in the reprocessor or the high-level disinfection machine. And at that time, you are checking chemicals. You are then, while you're waiting, you're verifying the process. You're looking at logs. There should be trace and trackability, that the serial number along with the cycle time, with the QC and the technician that performed it, that should be all tracked in your process for accountability. And in case if there would be something that came back of, say the device got exposed to an MDRO, it wasn't cleaned properly, that you can trace it back to the patient, so then let the patient know this event has happened and that you'll be tracking and following them outside of the facility to ensure that they don't have one of these types of infections. So then once the cycle is done on the reprocessor, the device is physically removed and it's placed in the drying cabinets in the right pressure, and it's hooked up to the airflow and it's freely suspended. So that means not touching the bottom of the cabinet, the side, or another scope. So along with high-level disinfection, their next component is sterilization, which sterilization removes all living organisms, and the SPD department is the primary resource and responsible for this task. They play a very critical role in reducing surgical site infections and other HAIs. So SPD staff are responsible for reprocessing contaminated instruments, and they also store a lot of our sterilized and clean equipment in the facility as well. They handle, they collect, they transport, they disassemble, they clean, disinfect, and sterilize. And everything should be cleaned, high-level disinfection, or sterilized according to the IFU. So every piece of device has its own set of instructions to ensure that it is being cleaned, disinfected, or sterilized appropriately. And just like high-level disinfection, we should audit this area to ensure that AMI, your AAMI practices, and Joint Commission and CMS, along with CDC regulations, are being followed. Just like high-level disinfection, you will see point-of-care cleaning, transportation to the department, the sterilizing of the product, and storing, along with verifying the processes. And here's just a little example you can see on the slide of the Bowie-Dick chemical indicators that should be both in sterilization practices. You have a biological indicator and you have a chemical indicator. This is just a picture of your chemical indicator that should be passed and ran during that sterilized process. So just like with high-level disinfection, the first step of auditing is coordinating with the OR, or that procedure suite, that, hey, you're gonna come in and watch the practice, the staff know, you're donned and you're donning the right surgical scrubs or PPE going in and to minimize that traffic flow. So you want to be in the OR with that, and then making sure it's an appropriate case to be auditing as well. That can be a big thing too. So definitely coordinating with that area is really, really critical. So while you're in the case that you are now, just like before, with high-level disinfection, you're seeing the physical removal of blood, tissue, and oil from that specific device. That is surgical shears, that's stitches, anything that's going into that OR, the physical tissue and blood should be removed either with a surgical spun or a lint-free cloth. And then it's just placed in a leak and puncture-proof container and then sprayed with your enzymatic spray according to that wet time. Then you are going to physically go with that device down to the dirty side of sterile processing. Sterile processing, depending on your facility, should be either set up in 2 or 3 different components. You're going to have the dirty side, the clean side, and the sterile side. And always when you're going in and auditing, making sure that you understand that flow so that you're not cross-contaminating those areas. And when you're moving from one area to the next, you're stripping off your PPE and you're putting new PPE on, and then make sure that you're performing hand hygiene accordingly. So when you physically arrive down to the dirty side of sterile processing, you'll see the device clean. That could be ultrasonic cleaning, that could be a dilution, that could be running it through a cleaning card, a cleaning area. It all just depends on what device you're specifically auditing and what the process is. It's always good for the sterilization practice to pick a device beforehand, read up on the IFU so you know exactly what steps are included and how they should be. Because there's a lot of different cleaning practices and sterilization practices of using different pieces of equipment, and it's different phases of how it goes from dirty to clean to sterile, so that you know exactly what you're watching and if it's within compliance of that from that IFU. So definitely take a look at that beforehand. So then when you're in the dirty side, you're watching them, you're talking to staff, you're asking about flow, you're asking about PPE. They know what to wear since they are handling very hazardous bio waste and they're exposed to a lot of chemicals. So you're making sure the device is being cleaned and that they are staying safe. Then once it goes into whatever device that you're looking at goes into the cleaning piece of equipment, then you're leaving, which is usually on a pass-through. So the area is kind of set up in 3 different zones, and that pass-through, once it goes, it's kind of like a dishwasher. You put it on the dirty side, and then when it's clean, it gets opened up on the clean side. So there's not this going back and forth from a dirty to a clean zone. So once you are there in the dirty zone, you come out, you remove all your PPE, and then you read on, and then you go into the clean side, and that's where then you'll see it get set up for sterilization. That's where you should see your chemical and biological indicators being put on the sterilizer. It should be, any devices should be fully open. For example, any type of scissors or surgical shears, they need to be fully open to increase that surface area. So those chemicals and steam sterilization, or if you're doing hydrogen peroxide sterilization based on your facility and the device, it can hit all areas of that device. So anything that is hinged, it needs to be open, and that you're putting little stoppers to kind of leave that open. So at that time, you're watching staff do that. You're watching them put in the chemical indicator specifically in the pack, and then you're watching them load it. And then in this area that you are also checking logs for temperature, air pressure, and humidity. Those are big requirements as well, to making sure that we're ensuring the right practices and that everything is within compliance, and that also you're not overweighting the trays. They should only be 25 pounds because 25 pounds has seen that someone can hold it freely away from their body and they're not bringing it towards their body, and therefore cross-contaminating it because it's touching their scrubs. So then you put it in the sterilizer, and you should have a chemical and biological indicator, and then once that pass is ran, you take it out and it's put on the clean side, or now the sterile side with all the other equipment, and then you're verifying your logbooks at this time to ensure that all practices have been and met quality standards. So why is this important? tracking and trending these specific areas are critical components. Not only is it a regulatory requirement, but it's specifically directly related to preventing harm to patients. And your auditing schedule should be based on your facility need. It will look differently based on your patient flow, your staffing, your availability, and also your coordination with those departments. However, it is recommended if you're having increased HAIs, especially on your surgical side infections, definitely auditing more in those specific types of cases and those procedures is a really great way to go in, observe to see what's happening so that you can stop patient harm and really see if it's a device or if it's a process breakdown. It'll really help identify those things. So definitely look at your staffing numbers, and then if you can audit at least per quarter instead of annually, I mean, the sooner you get in there, the sooner you can identify problems, therefore preventing harm. And then the next component we talked about extensively in Module 3 is construction. Here's just an example of the ICRA 2.0. If you need a refresher on how to complete that, please look at Module 2. And like anything, you always want to trend what you're doing in the facility. And this is a great way to have all your central ICRAs in one place so that you can monitor expiration dates and also identify if there's any issues, if there's any issues with construction breakdown, staff not being safe, breachers and barriers, therefore infecting patients. This is a great way to look at it so that at the end of the year when you're building that infection control plan and risk assessment, you can identify if this is a high priority or low priority based on the previous year. And the last main component that we look at is education, which is very, very critical. We do and see a lot of things. So keeping up to date on the current policies, regulations, and best recommendations is really useful and just very important. We provide a lot of guidance, policy creation, education, not only to ourselves, but to all the healthcare providers in the facility, along with patient education. So definitely trying to build in 30 to 60 minutes day for classes or weekly education that you can look at a webinar, a white paper, just review something on OSHA's website or CDC. It's really great that if you can have those small little breaks to really keep up with best practices. And then here's just kind of a great little bank of different resources, and all the links are at the end of the presentation. And then the second topic we're going to discuss today is how to conduct epidemiology investigations, which is a big component of surveillance that we do. It's also very time intensive, but as we've seen during the pandemic, this happens all the time. So we'll go through each step. So just as a refresher, we want to make sure, just like with surveillance, that we're using the correct term with the correct thing so that there's not miscommunication. And just here are some common definitions that we use. I specifically want to bring attention to outbreak. It says increase of number of cases. However, an outbreak, depending on the specific organism or patient population, one case can be an outbreak. So just keep that in mind. Say, like, if you had one case of Ebola, it's an outbreak and not multiple cases. So just be mindful about that when you're saying outbreak. It can be many cases, or it could be one. Some outbreaks, the threshold needs to be 10 or 20 cases to be deemed an outbreak. Other organisms, it's one. And it's important to know that investigations should be conducted in a very standardized way. Yes, you're going to have modifications based on the severity of the issue and the infectious organism, but overall, it should be conducted very standardized, and we'll go through the processes in a few slides. And something just to keep in the back mind, specifically when you're thinking about an investigation, is talking about that epidemiology triad of infectious disease. The relationship between the agent, the host, and the environment will definitely play into role. And if you need a refresher on those components, feel free to go back to Module 1. And so some just big questions that we ask before we start investigations. Is there an issue? And if so, what is the issue? Do we think this? Do we have a suspicion? Who do we need to alert? And then investigations will be conducted in 2 phases, both the initial and then the follow-up. And we'll go through each in detail. So in the first part of the investigation, which is called the initial investigation, the first step is to confirm the presence of the outbreak. That is, to understand what's going on and that there's a potential issue. And a great way to start is looking at your surveillance data and previous medical records and case counts. That's a great starting point to see if this is expected or not expected. The second step is to identify your investigational team and resources. So this is if you have identified a potential event, you're talking to your department, you're also letting your leadership know of, hey, this could be an issue. We're gonna do some stuff and we'll follow back up with you. And make sure it's clear that this is potentially an issue, not it is an issue. And then we're also identifying our teammates. Do we need other people involved with us? Since we kind of mentioned that occupational health can kind of be under its own umbrella, we're letting them know, hey, this might be an issue. We're doing some preliminary investigation and we'll follow up with you for support. And also our clinician folks too, if we're needing labs ordered or different things to be done, service lines shut down, cohorting patients, all of that. So you're kind of getting your team together and kind of identifying what resources. Is that certain swabs? Is that a policy? Is that shutting down service lines? Kind of figuring out what you're going to kind of do and kind of getting like a plan together. The next is to verify the diagnosis. So this is being done either with imaging or a laboratory result of saying that we have empiric evidence that this is a problem with this diagnosis, and then we're using that evidence to establish a preliminary case definition. And always when you start an investigation, you want your case definition to be very broad, so you're not missing any patients. It's always best to start with a very broad, basic definition, and then as more information comes about, that you're narrowing it down and kind of funneling it so that you're only including true positive patients. And then for step 5, after you have now confirmed this and you have your definition, your learning administration as well of, hey, we have confirmed this as an issue, because at this point you will need to call local or state public health to let them know. So it's always best as an organization to make sure we are all on the same page before we alert an outside organization too, especially that could preempt a for-cause audit right then and there, depending on what you're saying has, and that legally, administration, and operationally, you are ready, because at this point, in fact, epidemiology investigations are very disruptive. We'll shut down service lines, we'll shut down different components, it will disrupt daily operations, so that you're making sure that everyone is aware of the issue and collectively you have this plan and you're going forward with it. And now when you're calling local or state public health, will direct you. The next thing that they kind of might do is 6 and 7 kind of together is perform a literature review, i.e. they will be informing you of, hey, this organism has been seen in 2 other counties, or hey, this is a previous case definition, or yes, this organism is on the emergent pathogen list. Patients are presenting with X, Y, and Z. Can you order these tests as well? This is what someone else is doing, or this is what our standard procedures are, because they get a lot of information for CDC. So to standardize it, they'll know what to order, what to look at, give you recommendations as well, or direct you to resources. They might give you patient flyers, staff flyers of education that's already been put out, that you can start educating your staff on this emerging infection if they have not seen it before. And that will flow into your developing a methodology for your cases too. They will tell you what you should or should not be ordering. You'll always have to do at least that. Some other of your clinicians may want to order additional things. That's fine too, but at least being on the same path of, especially when you're going to have to submit this to local public health, that you're ordering all the right stuff at the right time. And then that information will flow into 8 when you're preparing your initial line list and epi curve. And so that's all the information that you're collecting. And public health can give you some guidance of, hey, ask about this, ask about who they were with, their exposure, their infectious period winding, and get that information as well. Because once the patient is discharged from the hospital, usually they follow up with them outpatient-wise. So it's a tag teaming of the case together. And here's just an example what a line list information you can collect. There's other ones that are out there, or you can create your own, or public health might have one too, depending on where they are on their education of tracking certain infections. And then the next step is going to be observing, physically going there and seeing what the process is, and then talking to your staff as well. Do you always do it this way? Do you know what you're doing? Do you feel confident answering questions, providing them education, especially if it's an emerging pathogen that maybe they haven't seen before? So you want to be watching them, auditing them, providing support, also kind of looking at operationally what you are requesting you can do and they feel comfortable and safe doing it. And then while you're doing that, also consider whether if environmental or healthcare personnel, if this is swabs need to be collected, if this is an environmental organism, of what that looks like, and then if this is a healthcare related exposure, that will also require potentially swabbing or asking staff to submit the sampling. Those two things are also, they're very expensive. That financial cost falls back onto the facility and can cause a lot of problems, especially with environmental sampling. You might find something else, but not your problem. It can be misleading. So just be careful with that. And then with asking staff members to submit to sampling too, there's some legal ramifications. So definitely checking with HR if you're going to go down that route, what's in your policy and procedure as an organization, what's appropriate. And then 11 is implementing initial control. So based on what you've seen, the data that you've collected of now implementing the things that are best practices and recommended to help stop the spread on whatever infectious organism that you're looking at. So once the infectious event kind of dies down, then we'll kind of go into the follow-up stage of the investigation. So once the main case count's there and then it starts to die down, then you kind of shift over in the follow-up, which is then defining and redefining your case information. Now that you have seen more patients over a set period of time, you are now kind of tuning down your case definition of what that specifically looks like, who's involved, and so you're taking that very broad preliminary case definition, and now it's going to be very, very specific. Then we go into step 2, which is continuing case findings. This is now where we're just starting to see a couple cases here and there, and we're still looking for them. Based on the time period or what we think is happening in the event. Say if there is, like for an outbreak, there is a chemical exposure and the TWA is set amount for people to come in with this chemical on them. Once that time has passed, that maybe you're not looking for those cases, or if it's the end of flu season, that you're starting to reduce your surveillance effort based on the infectious disease that is going on or the pathogen if it's waning down. And then at this point, you're wanting to review your control measures. Now that our case counts are lower, are these control measures really necessary? Or if they are necessary, are they still operational? Are we still using the right things? Do we need to increase it? Do we need to decrease it? Do we need to change what we're doing based on availability of equipment, those types of things? So now you're reviewing the process and making sure that what you're still doing makes healthcare providers safe and safe for our patients. And then we're maintaining our surveillance activity. So we're still looking for this, but now instead of active surveillance, now we're kind of switching over to past surveillance. So we're triaging patients, maybe asking a couple of these questions, and then which if they answer yes to or positively, then like it's prompting the investigation in a different direction. And then lastly, we're considering whether an analytical study is performed. And that's really up to the facility. The analytical study is very time intensive, usually involves other subject matter experts such as biostatisticians, maybe some other bioinformatics individuals as well. So it's really up to the facility or the unit leaders of a specific area if they want to go through and maybe publish a paper on this specific event, and that you're checking with your facility as well if you're talking about publishing a patient incident too, legally what that looks like too of checking. And then here's just an example of a data collection form that the CDC has. It's 13 pages, so you can take different chunks of it. They have demographics, they have past medical history, if it's an animal exposure, if it's a work exposure, chemical exposure, infectious, respiratory, anything and everything. So there's already forms that are publicly available for you to use. And then the last section that we're going to talk about today is communication and management practices. As we kind of talked about, IP does a lot, and we tell a lot of what's going on in the facility, not only with the educating our providers and our patients, but also developing policies. So communication is a pivotal function of that, what we're doing on the daily. So knowing the how, when, why is really important to know when to communicate, the time importance of it and how you're communicating, and not communicating misinformation, and that you're still communicating effectively while keeping the calm in the facility. So a great tool that some healthcare providers have been starting to use is called SBAR, which is Situational Background Assessment and Recommendation. It's a quick mnemonic that you can clearly communicate just, what needs to know on the topic. So S is your situation, which is just a clear, concise statement of the problem, short and to the point. B is your background, brief information of what's relevant. Sometimes, depending on the situation, there might be more information, but if you can give more concise, it's better. A is your assessment, which is your analysis and consideration of options, aka what you found or saw. And then R is your recommendation, what you're wanting them to do, or the action that they're going to take, or kind of like the justification of why you're wanting that. Say, like, I saw this issue, it's out of compliance with our regulation, please re-educate your staff on this policy, and then cite the policy that you need them. Or hey, this is emerging infections going on in the community, please be aware. I've attached some educational material of what to look for. Please huddle up with your team to make sure that they're aware, and let us know if we need to come and talk to them to provide them more support. Now, along with effective communication, it's a lot of knowing your audience. What you're going to tell your leadership, aka your C-suite, is going to be very different than talking to your clinicians versus your respiratory therapists versus your EBS workers versus your patients. So definitely knowing what information to disseminate and how you're going to disseminate it using your tone and body language is really important. No matter who you're talking to, you want a concise, informative, and very direct information message to them. And you always want to present yourself as very confident, professional, and empathetic. And definitely reading the room and the body language. There's a lot of times that we are communicating not great news, so definitely knowing how the pulses or the temperature on the room is really imperative. And you might get asked some really tough questions, especially if it's in a new emerging pathogen that maybe there's not a lot of information known. We saw a lot with this with COVID. Every day there was new information being put out, and we were re-educating, and literally what we said one day was different than the next day. So definitely, it's definitely okay to say, I do not know, I did not see that new regulation, let me go review it and follow up with you. That will really help get you a lot of respect of that, or, also praise other people of, hey, I read this report, or hey, I just saw this, that came out 20 minutes ago, did you get a chance to read it? No, I haven't, can you send me the link? Or where did you see that? So we're a big bucket of knowledge, but sometimes information comes out so quickly, it's great if they can help us. And then always just be direct and be patient. A lot of things that we communicate aren't great, so just be very patient and understand that this situation is very fluid. So with all the things that we have to do, managing the department in a very effective way is pivotal of getting all of our tasks done that we need to do. So the best way to manage a department is have your leadership, your director or manager up top, and then your other IPs underneath of that, and then break up tasks to specific units, different HAIs that they're working up, different departments that are responsible, as in like one individual is responsible for auditing high-level disinfection, other is responsible for auditing sterilization. Going to your surgical areas, going to your intensive care units, going, if you have any peds or any baby areas, going to your NICU, all different. And then rotating those tasks so that you can really help build a robust IP. So giving them an HAI workup, say, central line associated bloodstream infections, you'll work all of them up in the next 6 months and then switch it to, then the next 6 months they'll work up our catheter associated infections. That's a really great way to make sure that we are all educated on all the components of infection prevention, so you have a really robust team. And then just managing department responsibilities of breaking up by assigning different areas. You can break up rounding, audits, and meetings, and then structure your department as your daily, weekly, monthly, quarterly, semi-annual, and annually tasks so that you can stay on track. And then for our daily productivity, we always want to look at our microbiology results and our portal events. Those are very timely and they have time requirements. We're looking at isolation, we're doing surveillance, and then trying to build in that protective time that either is to committee meetings, root cause analysis meetings, KPI projects, and then that protective education time so you can stay up to date on what's currently going on. And then lastly, you always want to make sure that you prioritize, you have flexibility, and you're patient. So prioritize within the department who's responsible for what, and that's alignment with your leadership or executive goals, your facility, or your enterprise goals. If there are certain metrics that you're needing to meeting or certain issues that have been identified in your facility, you're really putting them on the priority list, and that you're flexible, knowing that you have your must do, should do, and want to do, which is great so that you can shift work around in case you have an infectious event that you have to start an epi investigation on. And then just be patient, knowing that things are constantly changing. One day you might have planned out you're going to do X, Y, and Z, but you come in and there's a TB exposure that you have to work up. So just knowing that everything can change and that's okay, and just be really flexible with that. So today we talked about a lot of different things, mostly that infection prevention programs are comprised of very critical components that keep our patients and our staff safe in the hospital. We talked about epidemiology investigations being a standardized process. And then we also talked about how to have effective communication and management practices to ensure that we get all of our work done, so that we can ensure that there are safe practices both for our patients and our staff. So we'll just do one quick announcement before we'll open up to questions. Module 5, titled Healthcare Associated Infections, will be on November 1st from 2 to 3. And we'll talk about the following components. Talk a lot about NHSN, look at definitions of HAIs and infectious period windows, along with some case workup examples. And then lastly, here's our QR code to our post-module survey. If you guys could take that and complete it, it's only about 2 to 3 minute survey. And at that time, you'll have a chance to enter in your email to potentially win some TEPHI swag that we would send out to you. So please complete so that you can get the free TEPHI swag. And then lastly, please connect with us. Here's our QR code so you can find out more about TEPHI and its different core programs and send us emails. And we just would like to thank you all for attending today's module, and we open it up for any questions. And then again, this was recorded and is posted to the TEPHI channel. So if you want to re-listen to the record, and the slide deck will be made available as well, too. Yes.
So I have a question here. What is the biggest challenge in epi investigations in rural hospitals versus your bigger hospitals like here in Houston?
I would say one of the two big things I would say is, one, knowing what to look for, being educated that this is an emerging pathogen, because usually those patients are presenting not typical to your patient population. So that's one thing of knowing, or you have specific risk factors of, hey, I was at this event, or hey, I was here. So knowing to incorporate those questions as well so you can properly identify the case. And then the next I would say would be your testing capacity too, of being able to collect that sample to run a diagnostic lab results audit. I know for COVID and for Mpox, even in the bigger areas, that's been really challenging because sometimes with emerging pathogens, it's not commercially available. So you can't send it to Quest or LabCorp or anything. You have to call your local public health department and then also know what type of transport tubes, media collection to, how long it can be stable in an area before processing, and then in rural areas, getting a courier to come get it in a timely manner and get it delivered to the lab too can be also a challenging component of that, of just having that type of resource and knowledge. So I would say knowledge and resources. Excellent question.
I had somebody online who would like you to put the references slide back up for a moment.
Yeah, so the references, there's 2 references. There's a lot of great things that you can look at here, and you'll be able, once we post the slides, you'll be able to access all the references as well. But here's just a few. And then each slide also has their specific reference, so when you're looking at the slide deck, if you're not sure, right in the corner it's cited as well. Any other questions? Well, great. We thank you all for attending today. Please, if you can, complete that survey, chance to win some TEPHI swag. And it was really great for us to get feedback so we know what topic to talk about and to better serve you. So thank you all.